Hello, my name Dr. Galina Bogoslovskaya. I'm from Queen Academical Hospital, Limpopo Province, South Africa, in collaboration with Dr. Yekaterina Jordan from Kolibri Cancer Center, San Antonio, USA. We would like to present paraneoplastic cutaneous manifestation of left atrial myxoma with case report and review of the literature. So, cardiac myxoma, the most common primary cardiac tumor. This tumor characterizes by wide range of clinical presentations that may mimic a variety of neoplastic and non-neoplastic conditions. Atrial myxomas present with symptoms include systemic embolization and mitral valve obstruction. Although 10% of patients may be asymptomatic, most patients present with constitutional symptoms such as fever, weight loss, weakness, myalgia, arthralgia as well. Cardiac symptoms usually manifest as dyspnea, palpitations, or syncope. These symptoms are related to obstruction of left ventricular inflow or elevated left atrial pressure. More severe manifestations also have been reported, including vasculitis, demyelinating neuropathy, and amyloidosis. Neurological manifestations are frequent and have been reported in 25 till 45% of cases. Different types of cutaneous manifestations related to cardiac myxoma are including Raynaud's phenomena, livido reticularis, splinter hemorrhages, blanching and blanching lesions of fingertips, violaceous eruptions with peripheral cyanosis. Toy necrosis have been reported as well. We report a case of a previously healthy female, 45 years old. She presented with 6-month history of constitutional symptoms and purpuric rash on lower limbs with no cardiac symptoms at the beginning and no neurological symptoms at the beginning. Later on, she was found to have cardiac myxoma. In our case, a patient, 45 years old female, presented with fever and erythematous rash on her feet that was associated with burning, numbness, and pruritus, which started 3 months ago. Her symptoms were slightly improved on Panadol and on cetirizine, which is antihistaminic medication. 2 weeks prior to this particular presentation, she noticed the onset of fatigue, loss of appetite, arthralgia, myalgia, and weight loss. She presented as well. She had no other medication use or no recent travel. With clinical examination. On presentation, her vital signs showed temperature 37.6 degrees Celsius, heart rate of 106 beats per minute, respiratory rate of 20 beats per minute, blood pressure of 140/62 millimeters Hg, and 97% oxygen saturation on room air. She had a blanchable retiform violaceous patches with few areas of true purpura on her bilaterally lower extremities. The remain of her physical exam was unremarkable: a regular heart rate, the rhythm with normal S1, S2, and no murmurs, raps or gallops, symmetric peripheral pulses, and joints with full range of motions without effusion or warmth. Neurological exam was normal with no focal deficits. Inflammatory markers were elevated and she was admitted for further evaluation. Initial diagnostic consideration were vasculitis associated with lupus erythematosus. Differential diagnosis we included vasculopathy due to antiphospholipid antibody syndrome, infective process, coagulopathy, or sepsis. Here we can see laboratory tests which demonstrating elevation of inflammatory markers like serum reactive protein being elevated and erythrocyte sedimentation rate elevated as well. Others are normal. From this table we can see that interleukin 6 been elevated as well. Antinuclear antibody titer came back negative. So extensive systemic workup was unremarkable and additionally included hepatitis panel, cryoglobulins, cardiolipins, complements 3 and 4, antistreptolizine O, titers, lipid profile, clotting profile, thyroid, functional test. So we just would like to show abbreviations which included to the tables. So skin findings at primary presentation we can see on this picture, including retiform patches, purpura, been bilaterally. We done biopsy which revealed Merriam vessel vasculitis. The patient primary was effectively treated with corticosteroids and discharged home. The importance of detailed physical exam we can demonstrate right now, because she returned several months later with more severe erythematous rash, cardiac symptoms as progressive dyspnea and chest pain. On cardiac auscultation, she had normal vitals, but been picked up a mid-diastolic murmur. Character and intensity of that murmur was changed with position, and early diastolic plop were heard. We did chest X-ray, mild cardiomegaly without signs of lungs congestion we can see on this chest X-ray. We did echocardiography, which revealed left atrium myxoma on echo. Here we can see on parasternal long axis view, which showing big myxoma in left atrium. Apical view showing the myxoma in left atrium as well. So then patient underwent uncomplicated surgical resection and the diagnosis of cardiac myxoma was confirmed histologically. She had uncomplicated postoperative course with resolution of fever, systemic symptoms in the immediate postoperative period. At 4 weeks follow-up, she continued to be afebrile with near complete resolution on her skin findings. She had no concerning symptoms even at her 6-month follow-up. Microscopically, resected specimen measured like 12/7.5/6 centimeters and weight 139 grams. Surface was smooth with spots of hemorrhages. Cut surface showed yellow to brown gelatinous material. Microscopical examination showed low cellular myxoid growth with numerous pores, nests, glandular pattern of stellate and spindled cells surrounded by eosinophilic to bluish matrix. No malignant features were seen. Here we can see near complete resolution on her skin findings. This may be 2 days, 1 week after operation. Later on, after successful resection of the left atrial myxoma, erythematous rash been resolved. So, all illustrated by our patients' recurrent fever, fatigue, skin findings, and elevated inflammatory markers, cardiac myxoma can present with variable paraneoplastic clinical symptoms that mimic other conditions. Cardiac myxoma, benign tumor, which account for nearly 50% of all adult primary cardiac tumors. Approximately 75 to 80% of myxomas located in left atrium. From 10 till 20% located in right atrium. 5 to 10% in both atria or either ventricles. Rarely, cardiac myxoma may be multifocal, for example, biatrial, biventricular, or together. Extracardiac manifestations are often caused by embolic phenomena, inflammation due to intrinsic secretion of cytokines. In a series of 112 cases in adult, 34% of patients presented with systemic or constitutional symptoms. 16% patients presented with embolic manifestations. Our case is a unique presentation with both systemic symptoms and vasculopathy, possibly due to emboli or vasospasm, highlights the importance of early recognition of the many features of these tumors to prevent morbidity and mortality related to emboli. The importance of a detailed physical exam was demonstrated. Paraneoplastic vasculitis is an under-recognized diagnosis occurring in 5.2% of vasculitis cases. Due to rarity of the recurrent conditions, diagnosis of malignancy is often delayed. Mean interval before diagnosis of malignancy reported to be 11.9 months. Diagnosis of vasculitis requires rheumatological and infectious investigation. Search for malignancy is mandatory when clinical course becomes chronic and refractory to conventional therapy. While there have been several case series of cardiac myxoma, mimicry vasculitis in adult and 2 reports in children. Our patient had evidence of vasculitis on biopsy, making it likely that systemic inflammation was the etiology of our patient's distal skin findings. Carney syndrome, to mention. Although atrial myxoma occurs sporadically, at least 10% of the cases are familial, the most common of which is the Carney syndrome. This autosomal dominant syndrome consists of multiple cardiac myxomas, a variety of pigmented skin lesions, extracardiac tumors, and melanotic schwannomas. Patients with Carney's triad are usually younger, comparing with our patient, and more likely to have myxomas outside of left atrium. Carney syndrome is also associated with increased risk of myxoma recurrence, approaching 25% after tumor resection. So, conclusion. Vasculopathic rash in the setting of atrial myxoma has been shown to be precursor to significant morbidity and mortality due to delay of diagnosis. Due to rarity of these presentations, time elapsed from onset of non-cardiac symptoms until diagnosis of myxoma is usually prolonged with interval development of irreversible neurological sequelae that reported in the literature. Therefore, we highlight the importance of including cardiac myxomas and paraneoplastic vasculitis early in the differential diagnosis for the patients presenting with purpuric rash and systemic symptoms. Key words: it's myxoma, cardiac tumor, purpuric rash, constitutional symptoms, neurological sequelae, paraneoplastic vasculitis, embolic phenomena, and our references. Thank you for your attention.